just a flesh wound. It's alive!
You can't handle the truth.
Go ahead. Make my day.
Say, all right.
Always live in awe of the glorious mechanism of the human body.
Brett, welcome back again. Thank you for being a repeat guest on the podcast.
No worries. Thanks for having me.
It's always nice to discuss with another person, and this one we're doing actually in person with the two of us, so we'll see how this goes as a first off trial recording. But today we're going to be diving into the shoulder as we've done before, but today we're going to be focusing more so on the actual rotator cuff itself. As we know, rotator cuff do such an important job, and in terms of shoulder function, they are one of the most important, if not the most important. So today we're going to be diving into the rotator cuff. We're going to run through some anatomy, and we'll talk about two common conditions, something that we see a real lot of in clinic, and obviously being our shoulder guy in clinic, you see a lot of these cases and some more complex than others. So to start off with, I think it'll be a nice one for the listeners if you can just run through some of the actual rotator cuff anatomy in terms of what muscles we're actually talking about.
Yeah, when we think of the rotator cuff, we think about, obviously we kind of brushed on some of these things when we did our frozen shoulder podcast, which I've had a lot of clients find value in listening to. So I recommend you go back, listen to that if you get a chance. But, when we talk about the shoulder, I kind of like to go deep to superficial. So obviously we've got, the shoulder is essentially a ball and socket joint. The ball is the top part of the humerus, and the socket is that glenoid fossa of the scapula. And then, overlapping that skeletal frame is the muscles, and the rotator cuff are the ones that we're talking about tonight. So you've got a few there. Probably the one that we see most clinically involved in issues is supraspinatus. So supra kind of means above, so it's on the top part of the scapula. And he kind of initiates abduction, so it's taking the arm away from your body. So he's probably the primary candidate when we have a rotator cuff pathology walk in the door. Below him, if supra is above, then infra is below. You have infraspinatus below him as well. He plays a bit of a role in external rotation, and he kind of sits on the back of that scapula and inserts into the humerus as well. We've got, the teres minor and teres major. Minors rotates in, major rotates outwards, and then we've also got subscap on the front as well. So subscapularis, which sits on the front half of the scapula, he pulls the arm inwards as well. So they're kind of the main muscles we talk about when we talk about the rotator cuff. But the anatomy guys, the anatomy geeks could probably talk about this for hours in terms of what else would you include as a rotator cuff. Like, do you include the lateral deltoid? Do you include the rhomboid? Do you include serratus anterior? So, these extra accessory muscles that also play a role in stabilizing the scapula, and some of those ones I just mentioned also move the humerus as well. So look, it's a really complex joint, which is why it's such a big issue for people, because it's our most inherently unstable joint in the body. So when you're doing occupations that involve a lot of shoulder movements, you're a plasterer, a painter, swimmer, throwing cricket ball, whatever, the more mobility, the less stability, you tend to have a bit more of a risk-reward issue with your shoulder.
Yeah, interesting. And I like the way that you pointed that out in terms of the not forgetting the supporting muscles that also do such an important job, right? And as you said, we can't have the one without the other, especially with the shoulder being such a movable joint, as you're saying there, and probably one of the most commonly injured because it's got so much mobility, right? But therefore, as you're saying, you get more mobility, but you're sacrificing stability, and that's where the rotator cuff do such a key job in terms of stability. And as you explaining there a little bit before about how they do the different movements or help out in initiating some of the different movements, but their real sort of job to stabilize that shoulder. Right, and it's a big job for them to do.
Yeah, and we'll talk, I don't want to get too bogged down in anatomy. I want this to kind of be a nice bite-sized piece for people to listen to. But, you could talk about anatomy for hours, but really the idea of today was to kind of talk you through what kind of symptoms you might be experiencing, how to help you identify, whether you've got a rotator cuff issue, but also then talking about how we, as soft tissue occupational therapists can help diagnose what's going on and help treat what's going on and get you back to doing those occupations you love. And that's why we would look at all those things when you come in, because, we talked about the core rotator cuff muscles being, again, supraspinatus, infraspinatus, both teres in the subscap. But most rotator cuff issues we see is there's a mismatch or an asymmetry or a problem with the interplay between those rotator cuff muscles and those other ones I mentioned that are involved in scapular stability. So when we get to the assessment part and the treatment part, we'll go over that in a bit more detail about why it's important. And as you just said there, each muscle has its own role, but they kind of work like a team. I often say to clients they're like a relay team passing the baton to each other. So we'll talk about that in assessment, but like with scapulohumeral rhythm, how the scapula and how the humerus work together, it's a bit like a dance. And if it's off, that's when we start to get damaging the tissues. And of course, we're doing these occupations and these movements thousands and thousands and thousands of times. So a small asymmetry can cause a large problem long term. It's a bit like having a loose nut on a wheel. If you're just driving down the shop, it's not a big deal. But if you're going to drive to Esperance or Albany, you might have an issue. So it's that same kind of thing. So, and that's usually how I like to explain it to clients. It's trying to use kind of everyday analogies like that to kind of help them understand how their pain started and why they're usually coming to us. By the time we see them, it's usually become quite a chronic issue, and I think that's why we get the results we do, is because we tend to break it down into those component parts, really analyze what they're doing and what's going on. And that's really, you can't fix a joint as complex as the shoulder without having a good understanding of that anatomy, and also having an understanding of what kind of demands this person's putting on them, and then putting that together.
Great point. And another one that you were talking about, which I really like to explain to my patients as well, about the smaller muscles, and you're referring to them as the deeper muscles, and then the superficial muscles being bigger. I like to say stabilizers and then prime movers, right? So those smaller ones that are closer to the joint, because they're a little bit smaller, they're going to have less biomechanical advantage to create a lot of force. Therefore, they don't actually create as much movement, but they do create stability, which is so key. And then once the joint is stable, those bigger prime movers, deltoids, lats, etc., can actually do their job more efficiently if they've got that stability. So as you said, that goes hand in hand. And if we want to be isolated and look specifically just at one muscle, which, as you said, we can get down to the nitty gritty, but remember that that's part of a bigger system. So just isolating by itself, you can come up a bit short if you just focused on the one muscle and not looking at the whole shoulder itself. But to segue into, as we said, we're going to talk about two conditions, and two of the most common. I think a good place to start would be rotator cuff tendinopathy, or old school saying used to be tendonitis. Rotator cuff tendinopathy. Can you briefly sort of, describe what we mean by that, and then we can dive into it in more detail? Yeah,
well, I think, again, trying to keep this as like layman as possible, it's really, you start getting these kind of small minor injuries or, micro traumas forming in one or two or three or four of those rotator cuff muscles. And they can be from an external, like a muscle asymmetry like we talked about earlier, so that humerus and scapula aren't working together very well. And, one muscle group's getting particularly loaded in a certain occupational task or movement. And over time, small little tears develop in each tissue, and then the body tries to repair those. But again, it's not getting that rehabilitation and rest it requires. Over time, you're getting scar tissue forming in these tendons, and they become brittle, they become hypoxic, which which means like a lack of blood flow, and that's when they start to look quite different to what you'd expect in a healthy vascular tissue. So tendinopathy is kind of like a slow burn injury. It's like we're going to get to tears in a minute. A tears obviously more when those tissues have had some large structural damage. Tendinopathies is more at that kind of lower level, where things aren't working well and haven't been working well for a while. And then the body's amazing. The body you will find other ways to do things, compensations. But you'll see, if you were to put that person into some imaging equipment or take a biopsy of that tissue, you'd see under a slide it's quite moth-eaten. There's inflammatory changes through that tissue, which is quite acidic. It's damaged the tissue. There'll be pockmarks of fibrin from the fibroblasts, which are the cells that are trying to lay down scar tissue to kind of allow some sort of contractile tensile strength in there for it. So you're losing, if you're going to picture muscles as having just for argument's sake, 100 motor units, you're losing those units. You're gradually losing bits and pieces. And so tendinopathy is where, the poor body's trying its best, but it's really not running. It's not running at full speed.
And I mean, we've dived into the tendinopathy in detail in a previous podcast. So again, listeners out there, if you're more interested, go and check that out. And the way I describe it, basically, like you were saying, is a change in the cellular structure, right, of the actual tendon itself. And again, the tendon is a part that attaches muscle to the bone. And the interesting thing with the rotator cuff is the large amount of tendon compared to muscle that those muscles have compared to, let's say your other bigger, stronger muscles, and the large proportion of the actual muscle is made up of tendon, and therefore, going to take a little bit more stress as well.
Yeah. And going back to that pass the baton analogy I mentioned earlier as well, like supraspinatus, he initiates abduction, and then deltoid takes over. But you think about most tasks that people are having trouble with, computer use. Most jobs now involve a computer. They're kind of unavoidable. So if you're on a mouse, again, who has perfect ergonomic posture? Not many people. But we really shouldn't be, again, taking that arm away, abduction. We shouldn't be abducting out to the point of like 90 degrees where we're compressing that point. But people do. I'll do workstation assessments as part of our holistic treatment, and people will have, next to the keyboard, they'll have a cup of coffee, their phone, documents. So that mouse has drifted further and further out. So again, that supraspinatus initiated that abduction and the deltoid took over. But then if you stop abducting, so you stop in space, then supraspinatus takes the baton back. And that kind of what we call isotonic or isometric contraction, where you're actually having to hold that limb in space. It's very demanding. It's very demanding. And I always play a bit of a trick on those clients too, where they'll, I'll kind of try and surprise them at work. They won't know I'm coming, and then I'll get them into that work position, and then I'll pull them away from their desks. I'll get them off the mouse, and I'll see how long they can hold that position in space. And it's usually not long at all. But again, when you're involved in a task, when you're in that kind of occupational flow, the hours go by and you don't necessarily feel those symptoms. So yeah, poor Supra, I think he kind of, he gets caught in a lot. And like you said, there's not a lot of, as we like to say in anatomy, synergists. He doesn't have a lot of synergists for what he does. He kind of is a bit of a lone wolf.
And as you were saying there before as well, the passing the baton, I love that analogy, but the deltoid is a lot bigger compared to the size of the Supra, right? Yeah. So again, as you said, passing on that load, it's going to bigger muscle, but then if that smaller muscle has to do it longer, again, a lot of load of work.
Have you ever seen an injured deltoid in your clinic?
I have once. It was a very freakish thing because I've spoken to clinicians as well who've had 20 years, and they've said they've never seen one. It was from a high force trauma. So besides that case, never ever had any deltoid.
Yeah, because I've been doing it 21 years. And I think I've seen one, and it was a high force trauma as well. So yeah, and then it's why we're doing this podcast, because rotator cuff pathologies are a large part of my clinic, and I'm getting more of them since we did our frozen shoulder podcast, and you've done that bursitis one as well. So these podcasts are clearly finding an audience. So I've actually had more shoulder referrals coming through since these have gone live. Yeah, I'm still yet to see a deltoid injury. So a lot of clients who are very knowledgeable in their own anatomy, they'll come in going, I think I've hurt my deltoid because the pain is on that lateral aspect. But it's, if you're a gambling man, the smart money is on supraspinatus.
Yeah, absolutely. I mean, on that nice segue there, what are some of the more common signs? Because I know you could call it sort of a slow burn, which is, again, a great analogy I'll probably steal. What are more of the common signs and symptoms when we're dealing with rotator cuff tendinopathy? What do you normally sort of hear in clinic that they report?
Yeah, well, people are just going to, it's not necessarily, large, excruciating pain presentations. They're kind of these dull aches. People have trouble sleeping on the shoulder, for example. There might be certain movement patterns that cause discomfort. And then the thing with tendinopathies too, which I think we should probably talk about as well, is, before we get into how we assess for them, is, again, we talked about this idea with frozen shoulder too, is that whole supply-demand concept. So, we talked about frozen shoulders forming when demand exceeds supply, and tendinopathy is exactly the same thing. In fact, actually, some chronic rotator cuff tendinopathies will eventually become a frozen shoulder. So it's the same thing we talked about. If you have some of those external factors we talked about a minute ago, the protracted scapula or occupational task demands, what we call a dyskinesia. So there's a mismatch between how those muscles are passing that baton. You're going to start getting these little micro traumas accumulate, the damage accumulates, and you develop these tendinopathies. So that's a case of the demand kind of exceeding the ability's supply, the body's ability to repair those little micro traumas on a day-to-day basis. But then on the other side of that, we can have internal mechanisms of tendinopathies forming as well, where the supply might be down, not so much because the demand is terrible because you've got poor mechanics or you're just asking too much of your shoulder with repetitive occupational demands. The supply's down because you might be a smoker. So the rotator cuff tendinopathies in smokers is much higher. Again, you might be diabetic. So there's high blood sugar, which is affecting your body's ability to vascularize that rotator cuff and meet those daily demands. Again, we talked about some of these things in the frozen shoulder podcast too. Your thyroid, poor thyroid function, poor liver function, clients with high cholesterol. we see it in some medications can affect peripheral circulation. So that's a point we should probably touch on too, is that these tendinopathies can form from demand, they can form from poor supply, so poor systemic issues. And unfortunately, if you're a poor person who's got a systemic health issue like an underactive thyroid, or you've got high blood sugar, and you're in a high volume occupation like commercial painting, or I've had a lot of Rottnest swimmers recently. We just had the Rottnest swim here in Perth. If your leisure occupation is swimming, or whatever demand you're throwing at that shoulder, if you've got a foot in both camps, you're a high demand occupation, and you have a supply side issue systemically, then you're almost guaranteed to be coming into my office at some point. So I just wanted to touch on that before I forgot. But so tendinopathies, people have these kind of consistent dull aches, pain laying on them, pain post-activity. With being tendinopathy, we've used the tendon, and then it's painful post-exertion. Once you kind of warm up and they get into their task, they're usually pretty good. And then it's as they start to cool down, as they start to stop, or break for lunch, they start to notice the pain again.
Yeah, and as you said there before, the load, I think that's the biggest one, as we know with tendinopathy, is load dependent is a big one, right? And that warm-up phenomenon, which is so interesting for tendons, and we've, again, done a podcast on tendons specifically, but that warm-up phenomenon, initially it feels quite gnarly. Then as we get more blood supply, releasing some other chemicals that are helping to reduce, pain sensitivity, it feels a bit better. And then when we slow down or we reach the peak when we overloaded too much, it ramps back up again. And that's another key one that I hear a lot of patients talk about is, first couple of reps at the gym are sore. Once I warm up, feel a bit better. And then towards the end of my gym session starts to play up again. And it's just load, as you're saying, right? Too much for it to handle, too much for that tissue to contend with. And then that's where, because of the cellular structural changes that have occurred, can't keep up with that demand, and then gets overloaded, and then we start to see issues.
Yeah, well, that's pretty a good segue into the tears, because you'll get these tendinopathies, these small micro traumas forming that gradually become bigger and bigger components of that tendon unit, which is affecting how torque's applied to the bone, and we get more and more issues, and eventually, hopefully not, but eventually then these things can develop into actual rotator cuff tears, which is where you'll actually get an actual macro trauma. So you actually get a large tear in the tendon or in the muscle belly, which is obviously going to be a lot more dramatic in the symptoms that the person's going to experience in this case. So these tend to be, not so much of a slow burn now, it's more of a big yell, because you're going to be getting people with quite a sharp pain. And again, with our tendinitis clients, our tendinopathy clients, you'll get them coming in. There's not usually a clear precipitating trauma. It's kind of like, it's just gradually getting sore and sore and sorer. Whereas with a tear, people will be like, I went to grab the kids' school bag off the back seat, and bang, or I was cleaning out the gutters and I just lifted up to grab something and bang. And so a tear will tend to have, not always, but will tend to have a more clear precipitating trauma. And the pain scale, the pain report's obviously much more severe, and the loss of function is much more noticeable. So, as the tendinopathy, as you were saying, like with that gym analogy, was great. They usually can push through it. Once it gets warm, they can push through it. Which if you have quite we do have a three grade scale for tears, but usually with a tear, if you try and push through it, you're just going to be in more trouble usually. And when we get to the assessment part of this podcast, we'll talk about how we can help you as a patient identify where on that continuum you are. If you're in the tendinopathy continuum, or you've graduated to the tear part of the pathology. But that's obviously why, again, and we'll get to this at the end of the podcast too, why maintenance treatment and looking after people who are in those high velocity, high demand occupations is so important to try and prevent that progression from tendinopathy to tear.
Yeah, that's it can be a very blurred line, as you're saying, that it can, if we again reducing the capacity of that tissue through tendinopic changes that have occurred, and then we overload it, we can go, as you nicely put it there, from that micro trauma into that big macro trauma. So I think segueing onto that, as you've sort of alluded to before, how would you sort of assess these pathologies? What are you sort of looking for in clinic in terms of assessing the rotator cuff?
Well, again, history taking is really important, because again, you're already when a person comes with a shoulder problem, you're already starting to kind of put these. You're a bit like a detective on the scene, right? Trying to put these pieces together. So, is the pain acute? Is it chronic? Again, as we just said, if it's a tear, it might be more of an acute presentation to you. If it's a tendinopathy, it's going to be more of a longer pain presentation. We will use a battery of standardized orthopedic assessments that we can use for rotator cuff issues. Probably the most well-known one is the Jobe or NEAR test, where we'll do a resisted abduction with the arm in internal rotation, which is mainly looking for our nice friend supraspinatus we talked about earlier. So we've got a series of standardized tests which have quite good validity and reliability, actually. So we'll use those to identify which part of that large group of muscles. As we said, there's a lot in there, so it's our job as a clinician to be able to help work out exactly where these things are. Again, coming back to tendinopathy versus tear, with a tear on these tests, we will tend to see with our manual muscle testing pain and weakness. So it's always good to compare with the asymptomatic shoulder. And again, to be honest, you'll often find some tendinopathies forming in the asymptomatic shoulder too, because these patients are, as we said, they're doing quite demanding occupations or leisure pursuits. So, it's rare to have one injured shoulder and the other shoulder is 100% crystal clear. Yeah. So I always like to assess both shoulders, and also with treatment too. When you are, we talked about it earlier in the tendinopathy, we talked about, I think you mentioned that cellular matrix. You've got infiltration of inflammatory chemicals, cytokines. There's all these inflammatory pain-centered chemicals in there. When you're doing a manual therapy like a soft tissue treatment with a patient, it is actually sometimes helpful to palpate the asymptomatic side, so the patient can get a sense of just how the tissue does feel different to them. Then it does feel thicker, painful. So that's actually a good educational tool as well, because when my clients come in, I really like to try and really explain to them what's going on. I think, informing your client is really important. I had a patient today, it wasn't a shoulder actually, but another pathology, but she'd been seeing another clinician and they hadn't really talked to her about any aspect of her pathology. It was literally like, this is what it is, you need to come in this often and this is how it works. And, they hadn't really explained the pathogenesis of what's going on, what her pathway to recovery should look like. And I think, information is power. And in a client-centered therapy, you should be really, hopefully, educating them and informing them about how they got here, how not to be back here again. So yeah, sorry, I'm getting my soapbox here a little bit, sidebar.
No, it's so key. And I probably almost said every other podcast, and just recently spoke about it on another podcast that I was a guest on, educate to empower. And I think that's what we do so well, right? You got to educate the patient on what's going on so that, number one, they can understand, but number two, they also understand why we need to do what we need to do, right? So whether it be a manual therapy, as you're saying, or whether it be a specific exercise protocol, if you just give it to them and say, go off and do this, probably less likely to follow through, versus you say, hey, this is why we need to do it because X, Y, and Z. This is the pathology that we're targeting. And if we don't do it, we're not going to get to where we want to go. So I think education is such a key point, right? It's such a big part of what we do.
Yeah. So that assessment process, obviously we're taking history, we're listening to them because their story is important, their narrative is important. I think a big part in healthcare, sometimes people aren't listened to about what's going on with their pain and also what's important to them. So I often say to them, what's the occupation we're trying to get back to? If they're a rower, I want to get back on the water or whatever. So, we've got a history, we've got a goal, we've got occupation of meaning. What are we trying to get them back to? Doing our standardized orthopedic assessments. So the kind of nuts and bolts medical side of that is obviously identifying where the pathology is. I'll actually watch the client perform certain movements so I can, again, assess that, as I said earlier, that scapulohumeral rhythm. So how those rotator cuff muscles passing the baton to each other, because at each angle of abduction, there's three key stages in abduction where those muscles are passing the baton to each other. So watching that upward rotation of the scapula in relation to the humerus, where are they failing? Where is their pain? Is it smooth or is it a real habit to get a real effort to get it up there? All these things are, again, building that detective analogy, kind of building the case file for you to kind of go, okay, it's this. And then again, obviously looking at posture as you mentioned, that, the kyphotic postures, winged scapula forward posture, large bust forward shoulder posture, that's going to be changing how those mechanical forces are acting upon the humerus. Again, the history, what kind of occupational loads this shoulder's been seeing and for how long. And, that really sound assessment is crucial for that next phase of treatment, because unless you really clearly define the issue, the treatment, it just doesn't work, essentially.
it's so detailed, and I think it needs to be, right, as you outlining there, in terms of we need to figure out what's going on and why it's going on. Otherwise, just chasing the symptoms. That's why I think a lot of we've got a lot of clinicians that listen to the podcast as well, and I think that's where a lot of people go wrong, is they specifically when they come to rotator cuff, is that they're just looking at the rotator cuff. And yes, that's important, but we also got to, as we first mentioned, look at the whole shoulder, the thoracic spine, what's going on with the scapular and the thoracic spine, the scapular-thoracic joint, what's going on from there. How is all of these little individual things all contributing to the dysfunction, right? And I think that's where a lot of people go wrong if we don't take that thorough assessment. Otherwise, look at, okay, we get a scan showing rotator cuff tendinopathy. It doesn't tell us why it occurred, and also doesn't tell us what we've got to do to fix it.
I'm glad you mentioned radiology, because I was going to mention that next. I was going to say, I often have patients come in with radiology, and I actually tell them not to show it to me, because I kind of feel like already it's giving you a tunnel vision. We just talked about the importance of being holistic, looking at the whole occupational person. So I actually would tend to not look at the imaging at all. And to be honest, imaging often isn't super useful in this initial context, because I think if you grabbed a random sample of people over a certain age, or the people that we talked about earlier with those high load occupations where we're going to be expecting some micro traumas in the shoulder, you're going to find a litany of issues on that scan, none of which might be actually important. So I think you've mentioned a lot of the reels and podcasts you've done on lumbar spine and disc issues. You've talked about that really, really eloquently, actually, about how the imaging is. I'm not saying imaging is a waste of time. It's an important clinical tool like any other tool, but it's not the only tool in the toolbox. And I think imaging, particularly with shoulders, it can actually send you down as a clinician, and clinicians who listen to these podcasts. I would take those with a grain of salt, because you don't want to be chasing a radiology report diagnosis as your diagnosis, because rarely it's actually the issue. And we're not going to, for the sake of brevity, we're not going to go into cervical nerve root pathologies too much here. But again, we can't assess a shoulder without, what supplies the shoulder? The cervical spine. So again, looking upstream, is this person's, if there is weakness, is there a cervical stenosis? Is there some sort of cervical nerve root pathology? We're not getting recruitment of those motor units. It's a complex thing. Like, if shoulders are easy, I think, I don't know if I'm, 21 years of treating, I don't know if you can call me the shoulder guy. But I think the reason why I'm probably getting some results with the shoulders that other clinicians aren't probably is more just that, as I said, just that kind of that thorough process, just kind of not having tunnel vision with images, listening to the client story, looking at the interplay between cervical spine, those supporting muscles we talked about earlier, the interplay between stabilizers and dynamic movers. And then again, we'll use that assessment process to guide our treatment protocol. And then again, we talked earlier about supply and demand. We have those external factors, so poor mechanics, occupational load, or those internal intrinsic factors, poor systemic supply, other health issues that will affect your ability to heal. That's when the assessment process is really important too, because you've got a client who's having these kind of large micro traumas or even a macro trauma with seemingly little demand, or you're getting these small kind of pock marks of tissue that aren't working properly, and they really should have healed with all the things they've done. That's when you can start to think about, okay, we need to get in touch with your healthcare professional, usually the GP in here in Australia, and let's look at why such a small trauma, such a small demand has led to such a large pathology. So sometimes having a thorough assessment process can actually help you identify other factors in the person's health. Massive,
yeah. And I mean, back to what you were saying earlier, you're definitely our shoulder guy at our clinic, that's for sure. If you don't want to refer to yourself, we will. But that's why, as you said, taking all of that into account. And in reference to the imaging, it's a cliche saying, but it's so true. You treat the person, not the image, right? You treat the person, not the scan. So all contextual, as we always like to say, it's individual to that person, but just because they've got a quote-unquote abnormality doesn't necessarily mean that it's pathological. And that's the tricky part. That's what you've got to differentiate, right? That's where the thorough assessment, as you were saying, and looking at all the factors, not just a piece of meat attached to bone, as we were saying before. There's so much more going on. And that's why, the assessment, we really spend so much time on the assessment, because we've got to figure out, like we said, the injured tissue or the structure, but also why, so we can actually get to the root cause rather than just chasing the symptoms. And so on that point, if we moving on to the treatment side of things, what are the sort of the normal treatments? Again, we know everything's contextual, but what are the normal sort of treatments that you're looking at when we're dealing with rotator cuff type issues?
Well, yeah, again, based on what your assessment results discovered, we then have to obviously resolve those issues. So again, our treatment model would involve, things like you might be doing some dry needling if there's some pockets of ischemia or hypoxia or taut bands in those tissues that need increased vascular supply. The dry needling also can help with pain in some of those movements. Some myofascial release of those tendons we talked about, a glenohumeral capsule. We might be doing some progressive stretching to restore mobility to those tissues. We're also going to be looking at doing obviously some strengthening when safe to do so. So we might be doing a graduated strengthening program. Again, when you start strengthening a group in a safe way, we're starting to, as you use those tissues in that tendinopathy perspective, you can actually start to change that cellular matrix. So by putting demand in the right type of orientation of demand and the demand in the right part of the tissue and the right activities, you can actually start to change that cell turnover in the right type of way, rebuild strong healthy tissue again, restore movement, reduce pain, and also just restore the person's confidence in being able to do A, B, and C. So there are those mechanical interventions that we do. Obviously, there's also then again looking at those tasks we mentioned. So we might need to change how a person's doing a certain occupational task or role as we're rehabilitating the shoulder, so they can keep being a productive person in that workspace or in that sporting endeavor. I had a client recently. I just said I'm not the shoulder guy, but I'm getting a few of these come through. Commercial painter, had seen a lot of other clinicians. Long time history of chronic shoulder pain, kind of living on non-steroidal anti-inflammatories and analgesic medications. But it was actually really simple. He had a terrible dyskinesia of the shoulder, so that passing the baton we were just talking about was completely out of whack. After such a long chronic pain history, he developed all sorts of compensatory patterns. And again, he'd just seen clinicians who had obviously looked at the imaging, just targeted that one or two bands of tissue out of the 6 or 7 that we have there, and then not working out why he wasn't getting any better. So we had to kind of change how he was moving. So kind of re-educating him how to abduct his shoulder by retracting that scapula first, like you said, getting that base of support for those muscles first. So we kind of had to pull him back and change, and it took a while because he had to re-educate him, how to load the things on top of his painting van, how to lift things correctly, in a safe occupational posture to allow my treatment on the table to work. And he'd had like a 7-8 year history of pain, and he hasn't, this is obviously not overnight, but it was only 4 to 6 weeks. He's now working without any pain. He doesn't need any medication, and as often the way these things go, I'm now looking after his wife for a different pathology and his daughter for a different pathology, and he's sent in his mother as well. So it's kind of, when you kind of create these meaningful results for people, they obviously they appreciate it, but then you kind of become almost part of the family really, because they start sending in everyone, because everyone's got their issues. So that was a really a perfect example in this context of someone with occupational demands, and there was an extrinsic problem there. It was the movement patterns, compensate, and then we've had to kind of like almost strip all that back to the start, kind of like an old piece of wood, like sand it back to the start and start again, and then build him up in the right way. Treatment will involve, dry needling, myofascial release, stretches, exercises, sometimes modifying the occupational task. Sometimes we might need to get in touch with the employer and make a few changes to their workstation. So again, it's that interplay between the person, the task, and the environment. And then, as I said before, if we do suspect there are some intrinsic systemic issues going on, getting onto those, liaising with the GP, and whether it's blood tests or imaging, whatever it is, to help us get all that data together so we can give our treatment every chance of success.
Brilliant. Yeah, it's so important. I think it's a great example there of just one of the patients, and I know there's many of them, but where I think clinicians can get stuck if they're just chasing the symptoms. As you were saying, you started taking anti-inflams. I don't know if you mentioned, or if I just heard it correctly, targeting with injections, one or two areas, but not looking at the bigger picture. And that's where, the rotator cuff rehab programs fail all the time, is that they're just focused on that by itself. Again, chasing symptom, not actually understanding the whole bigger picture in terms of what else is working up from there, and analyzing those things as well, which is so important, right? Both the intrinsic and extrinsic in terms of back to the supply versus demand analogy they talk about as well. It's so key, and that's where I think a lot of clinicians go wrong, is that they're just focused on the symptoms. They think that they've diagnosed it correctly, but that's just the tissue. It's not the why.
Yeah, and your bursitis podcast, like a steroid injection, an ultrasound guided steroid injection is usually the treatment of choice for subacromial bursitis. And it's not, again, it's a tool in the toolbox. But if that's the only tool and it's used in isolation, you're not going to get anywhere, because the forces, the dyskinesia, that mismatch, that asymmetry that caused that bursitis is still there. So it's kind of like, again, that car analogy. If there's some sort of issue with the axle and it's caused a problem with the wheel, you replace the tire. That tire's going to fail again. So so again, the clinicians that are listening, I'm not saying imaging is bad or injections are bad. In fact, they're really good, but we tend to want to do those towards the end of our journey. So I like to use, if there's a really chronic subacromial bursitis, let's do the injection last. It's different if the bursitis is so severe the person can't lift the arm at all, can't brush their teeth, of course. But I had a client, again, photographer recently, commercial photographer. She came in with a supraspinatus tear and a bursitis. These two are they're synonymous with each other essentially. And again, for those of you playing at home, how would she do that? It was abduction. So she was lifting her camera kit over the tray of the ute. Again, not engaging the correct groups or the correct muscle groups. She wasn't really retracting that scapula and having a nice strong base on that thoracic cage as she lifted that heavy kit. She was quite abducted and quite forward of the body. A long lever is a weak lever. That's hard. And then I thought, when she came in, I did say to her, again, empower, educate to empower, talked her through it. This is our pathway. This is what we're going to do. If we get to this day and it's no better in these key areas, we might get an injection from your GP. When that time came, actually, by the time we got around to that part of it, we'd resolved the supraspinatus tear. Again, pain at night was gone. She had full range. And she said to me, "Okay, so do I get the injection now?" You said that might be the cherry on top of the cake here. And I was like, we don't need the cherry anymore. The bursitis is resolved. So again, it was just about, again, root cause. We got the mechanics better. And actually, by increasing that subacromial space, we actually allowed the body to heal that bursitis, on its own. The body's an amazing thing if you just give it a chance.
For sure. I think sometimes we get in our own way. Finishing up on treatments, because this is one I get asked all the time. Do all rotator cuff tears require surgery? And to preface this, a little bit, a lot of patients that come in and again, they got imaging and they go, "Oh, I've got a tear, I'm going to need surgery," right? How do you approach that with your patients or your clients?
Well, I didn't do my homework before this podcast, so I should have done a lit review before I came in here to get more concrete numbers on this. But I know I just poo-pooed imaging a minute ago, but for the clinicians listening, imaging can be really beneficial, because if you're quantifying damage, that's when imaging can be quite handy. So, there are some of those tissues, supraspinatus, for example. If you've got a high-grade tear and it's above a certain millimeter of, if it's beyond a certain extent of thickness, there are times we can start thinking about possibly something like that, a surgical consult, because if that amount of macro damage is so severe that, some of those ends, for things to knit, the ends have to be able to meet each other. So, in terms of like laparoscopic surgical procedures for rotator cuff issues, it's really dependent on, again, that might be more of a case when you're having these kind of high force velocity injuries where there's just so much damage to that structure that our conservative efforts, it's going to be such a long road back that sometimes it's worth getting a consult. And again, educate to empower. I often do encourage clients who, if that's a question, I encourage them to still pursue that avenue of inquiry while we're doing our thing, because often it's actually nice to kind of have your cake and eat it too. So sometimes I'll say, even if you're going to have surgery, you're going to need to have better mechanics and have a better shoulder. So let's do what we do while you're waiting to see the surgeon. And if you get to that appointment with him in 6 weeks' time and it's better, great. You can, we can cancel the appointment. And I'm pleased to say they really need to keep that appointment. Also, I'm covering my back as a clinician too, duty of care wise, where we are at least creating that that opportunity there for that client to get a good resolution if our efforts don't work as well. But in terms of, when to and when not to, that's actually a really difficult question. And I think you could probably, depending on what bias you want to have when you do your PubMed search, you could probably find studies that say non-surgical repair is just as good as surgical repair, or vice versa, depending on inclusion criteria, what you're looking for.
Exactly, and if any researchers can find whatever they're looking for, right? We know that. But I think a big point, as you're saying there, to I guess summarize, is that not all rotator cuff tears need surgical consults or operations, all that sort of stuff. It's context dependent, as we're saying, right? All the other factors that we've got to look at, and we know there's a lot of literature out there saying asymptomatic tears, as in meaning that the patient doesn't have any symptoms or any pain or quote unquote dysfunction, but they've got those changes in imaging. And again, that's where the context comes into it. But to sort of put a finishing touches on the rehab side of things as well. When are you looking in terms of the progression from your initial rehab, looking at more isolated isometric exercises, building from there, and then returning to higher function sport, all the rest of it? Are there particular markers you're sort of looking for? Again, case by case basis, but what are your sort of boxes that you tick off in your head?
Yeah, well, I mean, look, it's again, put on the OT hat, kind of champion OT here a little bit, but a core OT component is that activity analysis. So kind of breaking down. So again, that history taking, what is it we're looking to do? So if they're wanting to a certain task or a certain occupation, then we have to break that down into, okay, what are the steps that these muscles have to be able to do that? And then we like to break that down, again, going kind of proximal to distal, so like stability to dynamic. Because if a patient can't do a movement unloaded in the treatment room with guidance, and that's not a real world example, but if they still have pain in that supported type of movement, there's no way they're going to be able to do a movement on a sporting field, for example. So we kind of have to break down what they're doing, which sounds really tedious, but it's actually quite get a kick out of it actually. But it's breaking down where that passing of the baton is failing, and then targeting each one of those things, and then working out, okay, getting that movement, unloaded movement painless first, and then gradually increasing load, and then also just educating the patient in terms of trying to re-educate how to do those movements in more of a safe way. So yeah, with that kind of when to load and when to return to sport, it's really dependent on what they're doing. And that also comes back to that surgical question too. Your decision for a surgical repair, if conservative efforts are failing in certain aspects of their pain, it really depends on, well, what is that shoulder going to see? A professional athlete has a much higher bar than a weekend warrior who's just throwing the ball in the nets with his mates on a Sunday. And that's also the same with maintenance as well. So I've mentioned earlier, the public probably think of seeing a clinician when you're in pain and you're really struggling, but probably half my caseload are people that actually aren't currently in pain. So I actually see, this commercial painter, I'm now only seeing him on a 4 to 6 weekly basis, which isn't that frequently really, but he runs a very successful business. He's rolling out and working overhead large parts of the day, lifting paint tins, lifting long lever paintbrushes. That's a high demand. So even though I've now taught him how to do those occupational tasks and trigger less microtrauma, there really is no substitute. Even though he now warms up, like an athlete, I've got him warming up, I've got him stretching down, I've got him doing things to look after his tissues. There is no substitute for him coming in, me having a look at, picking up things before they become a problem. Again, doing some myofascial release, doing some deep tissue release, dry needling if it needs that. Sometimes just almost kind of like restoking the coals. Hey, remember this is how you move this? Remember that? Okay, yep. So just kind of retouching base. So I think if you are one of those people in that cohort where you've got a really high velocity, high demand shoulder occupation or sport, you're going to need maintenance. Just like, you're going to service a Ferrari much more regularly than you're going to service a Camry, that whole idea. And again, if you're the supply side, so if you're somebody who is, dealing with insulin resistance, blood sugar issues, cholesterol, etc., if you've got a predisposition to getting these microtraumas and getting these injuries, you'll also benefit from some more regular treatment to not allow things to get to the point where tissues are breaking down. So that's a really big part of it. And shoulders are probably, again, it's such an inherently unstable joint. We haven't been out of the trees that long. It's a problem. So, shoulder, you probably get more maintenance work with shoulders than other joints, just because of the high risk issues involved with such an unstable joint. And again, that's like the long distance swimmers. I look after a lot of long distance swimmers, and even though we sometimes will change their technique and we'll have to target certain groups that we're letting them down on in that symmetry, they still benefit from regular treatment just to maintain that key performance, particularly my elite swimmers who are competing.
Yeah, fantastic, and I like the way that you sort of break it down there. I think it's a nice buy-in for patients as well. So there's the old African saying, "How do you eat an elephant? One bite at a time," right? So taking that, it comes again from the assessment, but taking that down and giving to, excuse the pun, but bite-sized pieces. And that way, I also find that patients feel like they're actually progressing, right? If they say, okay, I want to be able to throw a javelin 150 meters, and they're not there by week 3, they're going to feel pretty despondent. But if you say, hey, this is what we're looking for this amount of time, then we should be progressing from that, then we should be progressing from that. It's a nice way to give them some agency as well, to go, okay, I actually am progressing, and also see that, changes are happening. But also it gets them to understand that, hey, we can't go back to 100% when we're still only at 15, 20%. That's the goal. We're going to get you back there, but we've just got to do it in the right way. And again, it comes back down to the assessment as well. So I think it's a big part of it. And I think to wrap up, because I'm cognizant of the time, but you've got a shoulder workshop coming up really soon. This will hopefully be coming out just before that workshop. And I think it's going to be super valuable, as we were saying, in terms of running through the assessments, what we should be looking for, not just, the isolated, but the bigger picture as well, which I think you do so fantastically well in terms of your practice and, your teachings as well. So for the clinicians out there that are interested, can you just run us through briefly what's going to be sort of involved in that work?
Yeah, when we do workshops such as these, it's a good example. It's great to get clinicians together, because we can make it, again, we talk about client-centered therapy, we can make a clinician-centered workshop. So if there's certain pathologies that you're having trouble with, we can kind of delve into, where some of those common errors might be. But yeah, we'll obviously review anatomy, palpation of these groups, going over our standardized and non-standardized orthopedic assessments, how to assess both the ligaments, the muscles, the tendons, looking at movement patterns, how to pick up dyskinesias in the shoulder, so you can better help your patients work out where they're failing in some of those occupational performance components. Evidence-based treatment methods. We'll work through some case studies together as well. And obviously, with our workshops, there's lots of time where it's small groups, lots of hands-on experience, because it's how you learn. So lots of palpation, practicing those battery of assessments, battery of tests, just building that clinical toolbox, so that when you then have a shoulder presentation, walk into the clinic, you then have more of those tools and those skills at your disposal to better help your patients.
And the one thing I really like about it is how, as you said there before, really quite keeping it a small group to be very hands-on. And I think, as you said, that's how you learn, right? You can read textbooks, you can, listen to podcasts such as this one, but actually doing it in person, and particularly doing it with somebody, with your years of experience and knowledge, and the shoulder guys we're saying, is having you there as well to look at different people, look at the different structures, run through case studies, so that people can actually get it's like being a fly on the wall. That's what I always like to say, is I would love to be fly on the wall, in different circumstances, seeing how experts in their field do their stuff, and that's basically what's going to be running from there. So yeah, if you're a clinician out there, OT, shoulder, interested upper limb, physio, other allied health as well, I think there's a few spots still left, so get in and book your ticket, because I know it's going to be a great one, as they always are. But thank you again for being on the podcast. I think it was a nice one to dive into rotator cuff, a very complex topic in of itself, so I think we did nicely to zone in on 2 areas there. But thanks again for being on the podcast, and we look forward to the workshop.
Yeah, no worries. Thanks for having me.